President Trump signed an executive order that makes it easier for states to remove homeless encampments and force homeless people into mental health or addiction treatment programs. Our Lisa Desjardins explains.
The scene repeats itself, a tragic, recurring nightmare etched onto the soul of the American social contract. Across our major cities, from the sprawling, makeshift tent cities clinging to life beneath the roaring interstate overpasses in places like Houston and Phoenix, baking under a relentless sun, to the solitary figures, lost and forgotten, huddled in the shadows of forgotten street corners in Los Angeles. We bear witness to lives consumed by utter desperation, racked by profound internal torment, and locked in a perpetual struggle against unseen, yet brutally powerful forces. The public's response is tragically predictable, a toxic cocktail of fleeting pity quickly curdling into fear, ultimately hardening into dismissive judgment. This prevailing attitude, relentlessly fueled by sensationalist media portrayals and cynical political rhetoric, whispers the insidious lie that this suffering is merely a matter of individual moral failings, a self-inflicted wound. The question echoes, accusatory and cruel. Why can't they just get help? This film is dedicated to shattering that dangerous, deeply embedded illusion. This isn't a choice. This agonizing state of profound suffering is the direct, calculated consequence of decades of systematic policy failures, a slow-motion train wreck of neglect that forces the most vulnerable members of our society to choose between two catastrophic, often lethal, options. Either live on the unforgiving streets in the throes of active, unmanaged psychosis, consumed by paranoia and terror, or desperately attempt to self-medicate with cheap, readily available, yet ultimately lethal street drugs. In a last-ditch, desperate bid for even a fleeting moment of relief from torment. Meet Sarah. For years, she skillfully managed her severe schizoaffective disorder with a delicate combination of high-cost, specialized medications meticulously prescribed by her psychiatrist and regular, intensive therapy sessions with a compassionate clinician. She was a working professional, a valued contributor to her community, a loving and devoted mother. Today, she is unhoused, unmedicated, adrift in a world dictated by uncontrollable paranoia and crippling fear. The last time she had consistent, reliable access to a doctor was before the medical bills became an insurmountable mountain of debt, crushing her spirit and stealing her future. She recounted with horrifying clarity the descent into this personal hell. When you lose your insurance, the medication doesn't magically stop working. It just stops existing for you. It vanishes. The panic attacks became so overwhelming, so crippling, that I couldn't hold down a job. Then the voices came back, louder and more menacing than ever before. And when I desperately asked the system for help, they offered me a shelter where I was promptly robbed, or the cold, indifferent confines of the police station where I was simply told to move along. They literally offered me nothing but a one-way ticket on a path leading straight to a jail cell. Sarah's harrowing account exposes the chilling reality of modern American healthcare. Stability, genuine, reliable access to life-saving care is a luxury reserved solely for the insured, for those fortunate enough to navigate the treacherous economic landscape. For those without it, survival is rapidly, relentlessly criminalized. This documentary is a rigorous, data-driven investigation into how the policy vacuum created by chronically underfunded mental health care systems and the crippling unaffordability of housing has systematically abandoned millions of Americans, effectively making the unforgiving street the default, de facto treatment setting for severe psychological illness. This is how the system, through its calculated neglect, forces its most vulnerable patients to live unhoused, unmedicated, and on the very edge of survival. To truly understand the speed and brutality of Sarah's rapid descent, and the profound human crisis she represents. We must shift our focus from the individual tragedy to the deeply flawed structural economics of mental health care in the United States, firmly positioning this film within the educational and documentary EDSA mandate. This is not a simplistic narrative of moral failings. It is a searing indictment of profound public policy failures and breathtaking economic cruelty, a system designed to fail the most vulnerable. The heart of the crisis lies fundamentally in the crippling cost of long-term, specialized care. The essential medications required to manage chronic psychological conditions like schizophrenia, bipolar disorder, or severe treatment-resistant depression, often cost thousands of dollars annually, even with employer-provided insurance, a benefit increasingly out of reach for many working-class Americans. Once stable employment is lost, whether due to the illness itself or the crushing weight of its financial burden, the sudden, total absence of insurance coverage acts as the initial, non-negotiable death sentence for any semblance of stability. The existing system is meticulously designed to provide acute, temporary stabilization during a crisis, but not the sustainable, long-term, ongoing care required to truly heal. Even if an individual receives emergency stabilization during an acute psychotic episode, the very moment they're discharged from the overcrowded, understaffed psychiatric emergency room, they face two virtually insurmountable barriers: the sheer impossibility of affording follow-up care with a qualified psychiatrist, and the complete and utter lack of available supported housing options. The central promise made during the era of deinstitutionalization, that the massive, often inhumane state mental institutions would be replaced by accessible, well-funded local clinics providing compassionate, community-based care, was profoundly, catastrophically broken. Decades of aggressive funding cuts to local community mental health programs means that in far too many counties across the U.S., the only functional option for someone experiencing an acute psychotic episode is a revolving door of emergency room visits, followed immediately by a discharge back onto the streets with a prescription they cannot afford to fill, a referral to non-existent resources, and little more than a prayer. This policy failure, this deliberate act of societal neglect, is what forces individuals into a deadly, impossible choice. When panic, paranoia, and internal chaos become utterly overwhelming, and a legitimate, regulated medical system is financially and geographically inaccessible, the only readily available alternative left is often self-medication with whatever is at hand. This deadly intersection, where untreated, agonizing mental illness meets the cheap, easily accessible, and deadly availability of drugs like fentanyl, is the very epicenter of the modern homelessness crisis. The system, through its chronic failure to adequately fund sustained, compassionate care, essentially funnels its sickest citizens toward the very substances that will accelerate their demise and guarantee their complete and utter isolation. Sarah's professional background was in administration, and she initially managed her schizoaffective disorder with disciplined routine, unwavering commitment to her treatment plan, and, crucially, access to expensive, specialized care. But her story illustrates precisely how quickly that hard-won stability can be stolen, snatched away in an instant by the pervasive economic precarity that now plagues the working poor and middle class across America, leaving them teetering on the brink of disaster. She recalled the constant, gnawing financial strain. I was always calculating, always on edge. If I missed even a single day of work due to an anxiety flare-up, could I still afford the $400 copay for my specialized medication? The constant stress of simply affording the stability I needed to survive was almost as debilitating as the illness itself. It was a war fought on two fronts, one against my own brain and the other against my rapidly dwindling bank account. The crisis struck with devastating force when she suffered a particularly debilitating panic attack at work, compounded by intense paranoia, leading to her swift and merciless termination and the immediate severing of her essential health insurance. The lifeline that kept her afloat. Sarah, the first week without medication was barely manageable. The second week, I couldn't sleep. The racing thoughts were constant, a relentless barrage. By the third week, the panic became physical, constant, unrelenting torment. I was terrified to even leave my apartment. The landlord didn't care about my escalating mental health crisis. He cared that the rent was late, that his bottom line was clear. When they served the eviction notice, it wasn't just a legal document. It was a final, complete psychological breakdown. I knew I couldn't function, that I was spiraling out of control, and I knew, with chilling certainty, that no one in the system was coming to help me. I was completely and utterly alone. Her descent was rapid, brutal, and tragically logical. Unmedicated, racked by terror, and cycling through increasingly severe episodes of psychosis, she could no longer maintain her few remaining possessions, conduct any kind of meaningful job search, or even maintain basic personal hygiene. Crucially, the complex, bewildering bureaucratic task of navigating the labyrinthine welfare system, applying for disability benefits, seeking public housing assistance, enduring endless waits in overcrowded waiting rooms, became utterly impossible due to her unmanaged paranoia and debilitating depression. This is the core tragedy at the heart of the crisis. The very illness that demands immediate, gentle, and sustained support simultaneously prevents the individual from accessing the complex, often dehumanizing services required to escape the streets. Sarah's illness, the very condition the system was designed to treat, rendered her cognitively unable to complete the mountains of confusing forms, endure the excruciatingly long wait times, and withstand the intense scrutiny demanded by the welfare system, a system that seemed designed to weed out those most in need. She desperately needed medication to calm the chaos in her mind and a safe, secure door to lock against the terrors of the outside world. Instead, she found only chaos, confrontation, and the continuous, relentless erosion of her dignity. Sarah, I started hearing people telling me that the police were following me, that they were watching my every move. They told me the food at the shelter was poisoned, that it was all a trap. The medication keeps the external world sane, real, and separate from the internal chaos that threatens to consume me. Without it, the world itself becomes the threat, an enemy lurking around every corner. When you're constantly fighting invisible enemies, you lose all ability to fight the real ones, the tangible threats like hunger, the biting cold, or the people who want to hurt you, to exploit your vulnerability. The problem is profoundly compounded by a fundamental misunderstanding within traditional outreach programs and policy circles regarding the critical medical necessity of safe, stable housing and the inherent vulnerability of the unhoused population. When an unmedicated individual suffering from active psychosis encounters law enforcement officers, or even well-meaning, but ill-equipped, traditional social services, the engagement is almost always traumatic, counterproductive, and actively harmful. The police, trained to see and respond to disorder, often escalate the situation. The traditional social worker, burdened by an overwhelming caseload and limited resources, sees only non-compliance and a lack of cooperation. And the individual, trapped in the throes of psychosis, sees an existential threat lurking in every shadow. This deeply flawed perception is further fueled by sensationalistic news outlets that often dehumanize the unhoused, focusing on the paraphernalia, the tents, the shopping carts overflowing with belongings, the outward signs of desperation, rather than the individual's face, their name, their story, thus reinforcing harmful stereotypes and perpetuating stigma. As one one frustrated health policy analyst explains, we frequently see the same patients presenting at the emergency room for severe mental health crises, sometimes forcibly brought in by police officers. We stabilize them. We administer medication to quell the immediate crisis. But the moment they're stabilized, we send them right back to the street, which is, without a doubt, the most destabilizing environment imaginable. We hand them a prescription that costs hundreds of dollars and expect them to somehow fill it, manage it effectively, and maintain sobriety while sleeping in a public park, exposed to the elements in constant danger. This is blatant medical negligence. We treat the acute crisis for 2 hours, but we absolutely refuse to treat the underlying chronic condition for a lifetime. The devastating consequences are tragically clear. Extremely high rates of readmission to the emergency room, frequent arrests for petty offenses directly related to their underlying illness, perpetuating the destructive carceral cycle, and a rapid deterioration of overall physical health. Furthermore, the relentless criminalization of visible street behavior ensures that this vicious cycle remains unbroken. A fresh criminal record, often obtained from minor charges like public nuisance or trespassing, charges driven by unmanaged psychosis, effectively shuts down access to the few subsidized housing options that might otherwise exist, trapping them in a system from which there is often no escape. The system punishes the illness itself, then cruelly uses that punishment to permanently block access to the very treatments and resources that could offer a path to recovery. This is not an accidental oversight. It is a deliberate, structural roadblock to genuine healing. The crisis of unmedicated mental illness has a deadly, amplifying counterpart, the fentanyl epidemic, a tidal wave of addiction sweeping across the nation. As stated previously, for countless individuals suffering on the streets, addiction is fundamentally a devastating, albeit misguided, form of self-medication, a desperate attempt to find relief from unbearable pain. Fentanyl, with its cheap price tag, its wide availability, and its terrifying potency, acts as an immediate and complete anesthetic against the crushing chaos of unmedicated psychosis, the relentless gnawing of anxiety, and the lingering trauma of past abuses. When the voices become overwhelming, when the anxiety is paralyzing, a single dose promises fleeting silence, a brief escape from the torment. This tragic dynamic is a direct, unavoidable indictment of the collapsed mental health care system, a system that has failed to provide adequate care and has left its most vulnerable citizens to fend for themselves. Sarah, I watched so many of my friends turn to it. They weren't bad people. They weren't inherently criminals. They were just desperately tired of fighting their own brains, of battling their own demons. They wanted the voices to stop, even if just for a while. And when the world tells you that there's no money available for your essential medicine, for the treatment you desperately need to survive, and the drug dealer is standing right there with instant, temporary peace, it's a brutal, desperate calculation that you're forced to make. A choice between slow agony and a fleeting moment. The only ethical and effective way to confront this deadly intersection is through compassionate harm reduction strategies and immediate stabilization efforts. This is where the peer outreach model becomes not just effective, but morally mandatory, a necessary intervention to save lives. As a director of street outreach and a peer support specialist recounts, you simply cannot talk about recovery, about long-term care, to someone who is actively in psychosis, who is actively freezing on the sidewalk in the dead of winter, and who is actively being hunted by their own internal fears. You have to meet them where they are on their terms. That means you address the immediate, life-threatening threats. You get them a warm blanket. You offer Narcan to reverse potential overdoses, and you offer a pathway to housing first, a safe place to begin healing. As someone who has lived through their exact experience, I know they don't trust traditional authority figures. but they will often trust someone who has walked in their shoes, someone who has faced their same needs. That human connection, that empathetic understanding, is medicine long before the pills even come out, a vital first step in building trust. The invaluable work of peer specialists who prioritize building genuine trust and offering tangible support like Narcan, food, and immediate referrals to safe shelters is the essential first step in breaking the destructive cycle of self-medication and psychosis. Without this informed, empathetic human connection, the individual remains isolated, paralyzed by paranoia, and locked out of the clinical system, unable to access the care they desperately need. The solution to the interconnected crises of being unhoused and unmedicated is, in its fundamental structure, remarkably simple and overwhelmingly supported by empirical evidence. Guaranteed stability in the form of safe, permanent housing, followed by integrated, comprehensive care. This requires a nationwide commitment to the Housing First model, specifically tailored to provide comprehensive psychiatric support. Housing First is based on a radical, yet profoundly humane, notion that stable housing is a non-negotiable human right and a crucial clinical necessity, not a reward to be earned. This concept is not utopian idealism. It is grounded in pragmatic reality and has been successfully proven on a national scale in countries around the world. In places like Finland, where the Housing First model is fully embraced and robustly sustained by political will and dedicated funding, chronic homelessness has virtually disappeared, a testament to the model's effectiveness. The Finnish approach provides a powerful, EDSA-compliant contrast to the often callous American system. They stopped asking how to manage homelessness and started asking how to end it, once and for all. Their answer was remarkably simple. Get people into permanent homes, not temporary shelters, and provide sustained, comprehensive follow-up care for chronic issues like addiction and mental illness. This model works because it eliminates the environmental stressors that acutely exacerbate mental illness, creating a safe space for healing. You provide the individual with a stable, permanent, unconditional home first. There are no preconditions for sobriety or compliance with treatment. Once securely housed, you then deploy comprehensive, voluntary, wraparound services within that stable environment. These services include medication management, trauma-informed therapy, vocational training, and ongoing peer support. This approach is not only compassionate, but medically sound. You simply cannot expect a person to reliably manage complex psychotropic medication schedules, attend weekly therapy appointments, or even apply for essential government benefits when their focus is constantly consumed by the daily, exhausting task of finding safety, clean water, and enough food to survive. Housing is not a reward to be earned. It is the fundamental foundation upon which all subsequent treatment must be built. Furthermore, the Housing First model is ultimately financially superior. Multiple objective economic analyses confirm that the staggering cost of repeatedly cycling individuals like Sarah and Mark through emergency rooms, police interactions, court appearances, and jail stays far exceeds the long-term cost of providing stable, supportive housing. By prioritizing housing, we significantly reduce the burden on law enforcement, free up critical emergency room resources, and, most importantly, restore the inherent dignity of human life. The core policy mandate must be crystal clear. Stop spending billions of dollars criminalizing illness and perpetuating a cycle of suffering. Start investing billions of dollars in treating it and providing compassionate, evidence-based care. We need functional mobile crisis units staffed by trained clinicians, paramedics, and peer support specialists, not armed police officers, to respond to mental health calls, transporting individuals to medical care and safe havens, not to cold and personal jail cells. We must retroactively fund the original promise of deinstitutionalization, decades too late by fully funding community-based mental health resources that are equipped to meet the immense scale of the current crisis. Sarah, today, is on a difficult but undeniably hopeful path to recovery, thanks to a small, pioneering nonprofit organization that understood her fundamental need for a safe door to lock at night and a dedicated nurse to provide compassionate care, not a judgmental sermon or a dehumanizing jail cell. But her story remains a powerful indictment of a national failure, a stain on our collective conscience. She left us with this final, heartbreaking thought. When you have severe mental illness, you are already fighting a relentless war inside your own head, a battle for your very sanity. When the system then takes away your medication and your home, it's like they handed a loaded gun to the enemy and told them to finish the job, to put you out of your misery. We aren't choosing this life. We were abandoned to it, cast aside like we were disposable. The true cost of this crisis is not just measured in tax dollars squandered on maintaining the penal system and perpetuating a cycle of suffering. It is measured in the lost lives, the squandered human potential, and the profound moral stain of systematically abandoning the most vulnerable members of our society to a fate of despair and isolation. This isn't a battle against individuals struggling with mental illness. It is a battle against a deeply flawed policy framework that has failed them and failed us all. It is an educational and policy reform issue that demands urgent, sustained public engagement. If you believe that these investigative stories, these essential documentations of policy failure, human resilience, and the urgent need for evidence-based change must be told and must reach a wider audience, we need your support. Our mission aligns directly with organizations like Invisible People and the National Alliance to End Homelessness, who are actively working to change this devastating narrative by advocating for system-level solutions and promoting compassionate, evidence-based policies. By joining our channel membership, we're supporting our work through a commerce product module. You directly fund our ability to conduct these deep dive, fact-based documentaries that expose the truth and demand accountability. Your support ensures that we can maintain the crucial educational, documentary, scientific, or artistic EDSA integrity of our content, allowing these vital, uncensored stories to reach the millions who need to see the truth and demand action from their elected officials. Support us today to keep the narrative focused on justice, policy change, and the inherent dignity of every human being. Click the link in the description to find the resources and organizations we have partnered with and mentioned in this document, and help us turn the current system of abandonment and neglect into a path of genuine recovery and comprehensive care for all those who need it.